Okay, let's take a seat and enjoy the next 30 minutes of an amazing program that has been implemented by Sunraysia Community Health Services, but has been well supported by ARRCH, and is a program that can so easily be implemented across Victoria to address the health inequities. But the first person that I'd like to introduce is Dr. Gina Agarwal. Dr. Gina Agarwal, this is her work from McMaster University in Canada. The program is well researched, well evidence-based, and has been an absolute success in Canada. And we were very fortunate, Sunraysia Community Health, with our relationship with La Trobe University, to be able to connect in with this program in Canada, and with Dr. Gina Agarwal, Evelyn Spelton and the SCHS team, we've been able to transition the Canadian model into the Australian context.
Nice to meet everyone virtually. My name is Dr. Gina Agarwal. I am a professor in family medicine at McMaster University in Canada. And I've been working closely with Simone for a bit, and she asked me to do a little presentation about the program that we've developed. So I'll just continue on. First of all, I just do a quick land acknowledgement. Our Department of Family Medicine is on the traditional territories of the Haudenosaunee and Anishinaabe nations, and this is covered by the Upper Canada Treaties within the lands protected by the Dish with One Spoon Wampum Agreement. So I am also, as well as being a professor, I'm a practicing primary care physician. And I established the Community Paramedicine at Clinic program in Ontario with all its components. And I'm going to explain to you a little bit about the program and how it came about and what the evidence behind the program is, and then kind of where we are now. So let's think a little bit about the creation and the development of the program in Canada. So we had been getting news headlines that looked a little bit like this over the past number of years, showing us that basically hospital emergency rooms were really overloaded, that there were lots of 911 calls, or as you would say, 000 calls happening, and that many of the calls that were occurring may not have been being dealt with in the most appropriate way. In fact, some of the stories that the media were covering were actually quite scary, involving people who didn't do so well because of staff shortages in the emergency rooms and basically botched healthcare encounters. So I was recognizing that we had some significant deficiencies in the Ontario healthcare system. Our emergency rooms were overloaded. We had rising numbers of 911 calls, and we had increasing delays in offload, and that's where ambulances wait for really long times outside emergency rooms waiting to see what happens to their patients. And then also COVID-19, the pandemic, highlighted the fact that these problems were much worse for vulnerable sectors of our population, particularly those in remote and rural areas, and those who had very poor access to healthcare because of their vulnerability. So many of the solutions that were proposed by government agencies have tended to be more focused on downstream rather than upstream care. Now, I am a primary care practitioner, I'm a family doctor, and I tend to think about more upstream solutions for healthcare problems. So that's one of the reasons why we chose an upstream approach. So rising levels of 911 calls are increasing quite markedly. So we've seen increases of up to 5% annually, even up to 8% in some areas in Canada. And really older adults in our demographic make up 38 to 48% of these EMS calls that are occurring. We think that frequent callers can make up some of these visits, and it's really because these individuals are suffering from loneliness. They have poor access to healthcare. They are in situations of poverty, and they have poor quality of life. And the need for care is increasing, as I'm sure you all know, amongst older adults, particularly those age 85 plus. And you know, if we don't care for them properly, it can have multiple consequences. It can be costly in terms of healthcare. They can need multiple medical resources and time, and it can really reduce their quality of life. So let's talk a little bit about CP at Clinic and actually what it is. It stands for Community Paramedicine at Clinic. And it is a standardized out-of-the-box community paramedicine program. It's an innovative program that we have developed in Canada at McMaster University. It's evidence-based, based on about 10 years plus of robust research, and I'm going to share some of that evidence with you in a minute. It's a chronic disease prevention and management program, and it has a significant health education and health promotion component. We use validated health risk assessment tools, and we link these health risk assessments that paramedics will carry out to their primary care providers. We use decision support using algorithms that we've programmed into a database that we use. And we update our database continuously to reflect the best clinical practices that are out there in the evidence. So the CP at Clinic program has a paramedic training program that goes along with it. This training program provides paramedics with the competencies that they don't have because they're not trained in some of the things that they need to be trained in for upstream care. However, we train them with the CP at Clinic program. The training will cover physical and mental health conditions that older adults and vulnerable populations are impacted by. We also train them on the tools to assess these health risk factors, particularly in chronic conditions such as diabetes, chronic heart failure, COPD, dementia, and other conditions. And all the tools and all the everything that we're training on is based on the best available medical and healthcare evidence that's out there. Actually, our training is accredited by the Global Paramedic Higher Education Council as well. So our CP at Clinic program has a smart database as well. This database has built-in algorithms that will explain to paramedics or show paramedics what they need to do next or what recommendations they can make. So it helps them make decisions about what to inform their patients as they're seeing their patients. It will provide assessment results and recommendations for actions after they've done these health risk assessments. It'll also provide information about locally available resources in the community so that paramedics can then redirect individuals who they're talking to various healthcare resources in their community. Also, we have automated alerts that will notify the paramedics when to repeat the assessments and when those should be conducted. Also, these reports are sent to a participant's family physician. So our target population is vulnerable individuals who are low income, older adults, and usually they're at risk of cardiovascular disease, diabetes, and other chronic conditions. And the CP at Clinic program has been implemented in multiple different locations, social housing buildings, homes, shelters, long-term care facilities, places of worship. And it's also very adaptable and can be adapted to other forms of transitional housing, welcome or community centers and hotels, for example. So here's a little video I'd like to share with you.
I've been at the program since its inception. I think the program is just amazing. Saved my life. It did.
It's the best system that ever come to this building.
I mean, the great thing is that now my blood pressure's being taken. I'm monitoring my diabetes.
Could talk to the EMS people, what's wrong, or if you don't feel good, if you have been at the doctor, is there any danger of doing certain things? Even the doctor sometimes doesn't have the time to talk to you. So the EMS people really help you to understand with what you are coping.
The people come down, it's not only just the testing and the advice that they give, but it's almost become a social event for some of the tenants in the building. A lot of them are alone. They don't have families coming to visit them. So they come down here and they sit and they chat. And it's just a wonderful thing to see. And I thank them.
So keep on coming back. That's all.
All right. I hope you can hear that okay. I'm just going to go on to some of the evidence that we produced for the program. So we've had multiple papers published in very well-respected medical journals. Can you hear me still okay? Okay, because I can just hear a bit of an echo, that's all. Anyway, let's carry on. So we performed a randomized controlled trial, and our randomized controlled trial was conducted in a number, actually 32 social housing buildings, which were very large. But the long and short of the trial was that we were able to demonstrate a 19 to 25% rate of reduced emergency calls across, any kind of analysis that we did in that randomized control trial. And we had buildings that had the program compared to buildings that didn't have the program. So it was a very significant trial. We were also able to demonstrate improvements in diabetes risk and also a significant improvement in quality of life in most of the domains, such as self-care, usual activities, pain and discomfort, and also a sustained decrease in blood pressure of individuals who had participated in the trial. And this was really a very, very large trial. And it was a very positive one as well. We were also able to demonstrate that the Community Paramedicine Clinic program was a cost-effective program. For every $1 spent on the CP at Clinic program, the emergency care system saw $2 back in benefits. And in addition, the program cost per QALY gained by patients was actually lower than the Canadian threshold for adopting a program. So again, very positive finding for the program. So the current state of the CP at Clinic program is that it's being implemented in more than 50% of Ontario paramedic services, and also scaled up to other locations in BC and other places as well. And populations that are now benefiting from CP at Clinic are those who are waiting to enter long-term care, people with multiple chronic diseases, those who are receiving remote patient monitoring, other vulnerable and frail older adults, people who have been referred by paramedics into the program, those who have limited mobility, people referred by hospitals, and others who have been prioritized by Ontario health teams. Let's share a last bit of testimony with you.
The first clinic that we opened, within 6 months, it was quite clear that it was having a good effect on our residents, our vulnerable seniors.
Not only is there less calls to 911 to these buildings, but I found when I was called that the patients knew more about their disease, that they knew when to call. That makes them a lot happier, them a lot less worried, and they know the appropriate times now to call. So it's a win-win situation.
Talking to some professional who takes the time, who also takes your blood pressure, your sugar level, et cetera, you walk away that you feel a little better than just the no-hip number.
They trust us, they see us, they know us, they're more likely to tell us things.
He doesn't diagnose, but he can tell you, suggest to you, like, maybe it's time to visit your doctor. Maybe you should go, and here's a question you can ask. But the program has certainly pushed me in the right direction.
On top of that, we build community relationships with a lot of partners, putting them in touch with Meals on Wheels, putting them in touch with services at the region they might offer for tax clinics.
If we need some help, they can give us some information about who in the community can help us.
And even something as simple as getting somebody a walker, because they don't know how to navigate the system.
So building community partnerships is huge. There are people out there that are available to help them. It's just that they don't know how to access that.
I think it draws people together a little bit more because usually people stay within themselves. They're not too social, and stuff like this promotes sociability. I am very grateful to be part of this.
It's a great win for the paramedic service. It's a great win for our paramedics, and it's a huge win for the seniors that are isolated at home.
So, CP at Clinic internationally. So we have a wonderful partnership with La Trobe University. Through this partnership, we have been trying to scale and adapt CP at Clinic to different Australian settings. And we had located suitable sites, and Sunraysia Community Health Services was a prime location and was ready for implementation. And we've had meetings with Simone in the beginning, and really the rest is history. We have a wonderful partnership, and I believe Simone is now going to share some of the information from the CP at Clinic adaptation in Sunraysia.
So for those of you that don't know where Mildura is, we're just at the top of the state, that beautiful green dot there. As Gina said, we're the perfect location for this type of program. Our health system in Australia is the same as what they experience in Canada, and certainly the vulnerable communities that we work with in rural and regional Victoria are the same as well. So it was a well-suited program for us. So ARRCH embarked on CPAT team because, we work within that social determinants of health framework. We specialise in addressing the health inequities, and we specialise in social connectedness as the community health sector. As I said, the health system we know is under significant pressure, and this was a significant opportunity to tap into a workforce that we had never used before within the community health sector. But the bonus for the paramedics is they had a very narrow opportunity. Once they moved out of the acute service, there was not much more for them. So this actually now allows paramedics to remain within their chosen discipline and move into the community health sector, as all of the other health disciplines within our health sector have that ability to do. There's a definition of what we follow as what a community paramedic is. Oops, I've missed something. So the Australian program follows the same principles and utilises the same training, database, tools, all that we get provided by McMaster University. The Canadian model's called CP at Clinic, but within the Australian context, it's called CP at Team. And the reason that we have called it that is to clearly differentiate this is a community health sector service. It doesn't sit within the acute sector. And it's a multidisciplinary approach with people with lived experience as part of our workforce and a multitude of healthcare professionals. So how do we transform? Down the bottom there. How do we transform healthcare? And it's only possible when everyone comes together to power that change. So the first major piece of work this has been about is the relationship. And it is the relationship that we developed with McMaster University, La Trobe, and Alan Eade at that time was at Safe for Care Victoria and was an absolute support to us in so many ways. It is about our relationships in the organisation. So we implemented a program that had not been done before, and we employed a discipline that hadn't been done before, and so it was quite nerve-wracking for some people. Linda, who had to manage it all. So Linda Henderson, Ruth Hardman and Callie Nace, we've got a strong research academic component behind this, and then 2 community paramedics that had never ever worked with Sunraysia Community Health, and thank goodness just took the risk to come and work with us. And certainly because of our relationship with the community. And we work within that relationship-based framework, and it's our community that continue to drive the way we implement the program. Innovation. By God, you need some innovation, and you need a gang to help you with your innovation, and certainly the ARRCH, the work of ARRCH has absolutely supported us to continue to drive this change. In mobilising change, we always have to push the boundaries, and push the boundaries we did. We were told many times that we could not do this. I didn't listen to that. We, as I said, we employed paramedics. We followed the expertise and experience of McMaster University. And when we hit a hurdle, another important component that we had in this program was the expert advisory group. So when we had a couple of incidents where Linda would come into my office and say, guess what's happened? And I'd go, we would get hold of the expert advisory group. And once again, with the leadership of Alan Eade, he would diffuse the situation. He would help us put that in perspective and help us to continue to drive the program forward. And why in the community health sector? Because community health, we know our business. We know the population level data has not improved. We know that the traditional models, characterised by siloed service delivery, institutional settings and processes, are not effective in combating the complex social health issues that we see out there in our community. And we know that community health sector has the absolute capability to influence change within the health system by designing and implementing programs that are innovative, community-led, and address the current health inequities which we are seeing within our communities. As Gina demonstrated, it's also very cost-effective. So it's a very economical program, and at Sunraysia Community Health, what we did was we Linda reconfigured some of the community health funding that we had, and you can see there for $220,000 of paramedics, it's resulted in 1,368 interactions. And those interactions have occurred in a multitude of ways, which Linda will talk about. And the other way is of transforming healthcare is really understanding the magic of the model that we are implementing. So it's innovative, it's place-based, it's led by community. We listen, we learn, and we implement. And in this case, the bonus of this program is the community is the client that attend, but also we've got community connectors. So employees who live in social housing, whose expertise in knowing their community is an absolute winner in making this program work. And it's adaptable, and so the program changes according to which area of Mildura we're in. And you wouldn't think that. You wouldn't think that we would have different programs in such a small area such as Mildura, but what they're doing in Redcliffs is completely different to what they're doing in Merbeen, once again led by the community. So I'll just hand over to Linda, my colleague, who is going to tell you about what it's like putting it on the ground, these great ideas that we have.
Thank you, Simone and Gina, for setting the scene. And I know we have gone into morning tea, but I did just get the 5-minute warm-up. So I appreciate that you are sitting through this during morning tea. So what does the program look like on the ground in Mildura? The CPAT database that Gina spoke about has got that suite of chronic disease screening tools, Timed Up and Go, Frailty Screen, Minicog, all screening tools that you would be well aware of. The only change that had to be made was to the to insert the AusRisk and remove the Canadian Diabetes Assessment Tool. Then we also needed to include all of our local community services, all of the Australian health literacy documents and health education. So we've done all of that work for the Australian context, but it does need to be localised to your local community with referral pathways. We were lucky with the community locations. We built on the strong work that we'd done, the relationships, that's a word that we've heard a lot over the last couple of days, that we'd built during ARRCH. So that was an easy thing for us to find places to run the clinics. And we were able to align with opportunistic funding sources that were really complementary to the CP at clinic. So vaccination pop-up clinics and the community connector funding. And in our region, flood was a big issue late last year. So this enabled us to provide food parcels, care packs, and to employ the peer workforce, the community connectors. These activities provided an excellent pathway to the CP Act service and significantly increased engagement. So this is an overview of our uptake and participation. So we started in August last year with 1 clinic. We're now in 5 locations a week and providing, in August we did 96 consultation with 6 new clients. So the uptake has been really good, particularly in centres that were similar to the Canadian setting. Public housing, retirement areas and community centres that were within walking distance. So again, this highlights what Simone has mentioned. Community connectors, as many of you know, are a peer workforce with lived experience in public housing. They provided the interface between the community and CP at. They were able to quickly build relationships and trust within their communities to connect people into the service. Over the last 12 months, our complementary activities have grown. We've got 2 community walking groups with about 20 people coming to those each week. We're doing 65 community meals, which we'd never done before. We're providing 45 food parcels in 2 different locations. The community meals and the food parcels also provide an opportunity for that social interaction and engagement in the CP Act clinic. Community events such as vaccination, community garden and health education are all valued add-ons that have really contributed to the positive early engagement in the CP Act clinic. So what are the early results? People loved it. We're just concluding the program evaluation now. We knew the program worked in Canada, so this evaluation focused on whether the program would work in a different setting and context. And my colleague Ruth Hardman has done this in consultation with McMaster and La Trobe, has used this framework for evaluation. So we interviewed clients, staff, SCHS staff and stakeholders, and we looked at the database to inform our evaluation. So acceptability, did people like it? The program had really high levels of acceptability. As I said, people have loved it. They felt safe and cared for. They reported increased social connection as a result of attending the clinic. And the other thing was the paramedics found it really rewarding and felt that they were helping people more than they had been able to in the acute setting. Adoption. What was the uptake? As you've seen, the uptake was strong. There's been good uptake also for expanding services further amongst community members with complementary SCHS programs now attending clinics weekly. Appropriateness. Was it a good fit for the population? The program was seen as appropriate for the target population due to it being free. It was weekly drop-in and the locations were within the communities that people lived. Fidelity. So we were looking at, was it true to the Canadian CP Act clinic program and were any changes needed? The program was consistent with Canada, although there's been some challenges for our community, particularly in relation to accessing onward referral to GPs. Adding in community meals and the walking groups has certainly strengthened the engagement with the service. As Simone's talked about, implementation costs were very low and our implementation was significantly enabled by the support we got from McMaster and La Trobe University during this implementation phase. The penetration. This is the meaty bit. So the service has successfully targeted the intended population. Most of our clients that we've seen, 57% in fact were age 65 and above. 78% of the clients had 3 or more chronic diseases, 21% reported social isolation, 27% experienced income insecurity, and 36% of people didn't have a GP. We have done 66 onward referrals and 448 health education sessions during this first 12 months. So sustainability, can we keep it going? Sustainability showed that clients were motivated to keep coming to the service. The key sustainability challenges relate to the funding models for community health, which do not currently recognise the discipline of paramedicine. If anyone wants to talk to me about the challenges I've had with trying to convert hack funding for this program. You're welcome to. The other challenge has been employment restrictions that the paramedics have experienced with being able to stay in part-time roles with Ambulance Victoria and work somewhere else. So what did the community tell us? I'll just read the first one, but it's more of an open and free. It's not in a small office. You've got other people walking around in the foyer, and then you have community lunch, which is in the same place. It just feels like, I don't know, I've only been coming like since it started, but it's like a little family getting to know each other. And I should have pointed out all the people along the way have been our paramedics and our peer workers. So we're now really looking forward to seeing the impact that the program has had on our community members, which comes after the 6 months. So as you saw, a lot of our implementation has, we haven't had the 6 months reviews yet. So we're really looking forward to being able to look at that data in more detail. So I'll hand back to Simone about where to from here.
Great. Nearly done. So in order to keep this going, we've had great support from VHA, who placed the CPAT team as their first budget bit for May 2023 this year. We're advocating to state and Commonwealth governments, so we've had some great conversations with Louise Galloway and her team. And Community Health First are also strongly advocating for this program. We continue to roll the program out across rural and regional community health services by tweaking funding. So I'm aware that Trish is doing this, Trish, yes, and Gateway as well. Lee and her team at Gateway are implementing it. We just continue to develop the program at North Richmond Community Health, Sunraysia Community Health. I was doing so well. So just before I left, we purchased a van because we actually worked out that the van can just pull up wherever the community are and be able to care for the community. And we just continue to develop the evidence within the Australian and international context. So it certainly is a model that is so easily adaptable across our state that has such great outcomes for our community. And just to finish up, there's the gang, there's the ARRCH team that have just been instrumental in continuing to support Sunraysia Community Health to roll this out across the state. And one of my favourite sayings, why join the Navy when you can be an ARRCH pirate? ARRCH!
We are pressed for time, but thank you so much, Linda and Simone, and congratulations again on your leadership. It would not have got where it is if it wasn't for your leadership, so well done to you.
Thank you.